Okay, so the deltoid has an anterior, middle, and posterior part. So the attachments are the lateral third of the clavicle, the acromion, and the spine of the scapula to the deltoid tuberosity of the humerus. So just here, and there. It's
Okay. Oh, could you have Trevor turn around so we can see the posterior deltoid?
Then the innervation is the axillary nerve C5, C6. Its action, so the anterior part flexes and medially rotates the arm. The middle abducts the arm, and the posterior extends and laterally rotates the arm. So to test its strength, I'm going to have Trevor put your arms out in front, and then for the you would just go like this, and then I would push your arms down. So resistance. That. So that would be anterior. And then middle, I'm going to have you abduct your arms like this. And I would just have you go like that. And then resist it again. And then for posterior, I'm going to have you go in the same position and have you extend like that. And then have you push forward like that.
Okay. Are you finished, Kayla?
Yes.
Okay. So a couple of things, and Kayla did a fabulous job. Okay, but one thing that I'd like you to think about also is stabilization. So Trevor is young and healthy, and so, for example, if we were to look at the posterior without stabilization, so go, and the position was good, but the stabilization would be really helpful. Okay, so Trevor, hold it strong as you can. Oh, I broke him, or his elbow, I broke Trevor. But I mean that his elbow moved, so is it because, and hold it as strong as you can, ready? Okay, his elbow moved, but is it because his posterior deltoid isn't strong? No, you need to stabilize here. So for instance, you put your hand in the opposite direction. So you see I've got my hand in front of his scapula, so I'm stabilizing the trunk and scapular girdle from moving forward with this. And then I push, ready, hold, good. So we get a more accurate reading. Or if we're testing the anterior, ready, hold, that time I'm stabilizing from the scapula. Now, by gravity eliminated, what I mean is, Trevor, if you could come on down here.
Lay down.
Don't, well, no, just sit down. Why don't you grab the stool? Okay, and let's see, where is the pedal to control the height here? Okay, thanks. Okay, so the idea behind gravity eliminated is you are all young and healthy, but you'll be working with patients, and the patients might not even be strong enough to move against gravity. So you might check out and see if they can do some gravity eliminated movement or gravity reduced movement. So for instance, in Trevor's case, this time face me, there you go. And so you see what I've done is instead of him holding up the weight of his arm is supported by the table. And I'll get around behind him to stabilize. And if Trevor were not young and strong and healthy and needed some gravity support, we could test and see if there's anterior deltoid movement. Go ahead and slide your arm forward like this. So that's gravity eliminated. Or slide it backward. That's gravity eliminated for the posterior deltoid and some other muscles too. But that's what we mean by gravity eliminated, right? Okay, great.
So, hey!
Oh goodness, who said that?
That's my lovely assistant.
The lovely assistant.
So the subscapularis attaches to the subscapular fossa on the scapula, and then to the lesser tubercle of the humerus.
Hold on, we're taping this, so could we bring the, there you go, okay. Super, there you go.
So subscapular fossa of the scapula and lesser tubercle of humerus. test that, you have patient stand elbow bent at 90, and then it is an internal rotator, so you're going to try to pull them into external rotation, supporting the elbow. Okay? Next we have the supraspinatus, which is in the suprascapular fossa to the greater cervical.
Mm-hmm.
Yeah. Okay, and that is an abductor and external rotator. So I feel like this one is very similar to the middle deltoid.
It absolutely is.
Okay, so you're gonna have their arm abducted and just resist. Right?
Okay, continue.
Okay. Teres minor and infraspinatus are tested the same way, so infraspinatus is the whatever. And then to test that, you're just going to do the same thing as subscapularis, except you're going to be pushing them into internal rotation and they're going to be resisting.
Okay. So each of those actually are single joint muscles, right? They just cross the glenohumeral joint, so you want to test them in the shortened position.
Okay.
Now, when you test them for, and maybe you've done this already, for musculoskeletal, you're kind of testing them for different things. You're testing them for reproduction of pain. But if you're testing for strength, you test single joint muscles in the shortened position. So can you think of a way you would test those muscles in a shortened position? So, okay, well, can I show you?
Sure.
Okay, so for subscapularis, right here, ready? Hold it. And there's other ways too, but you want to shorten it somehow. For infraspinatus, for supraspinatus, you want to get it in more in the shortened position, so get her up into abduction. For infraspinatus, we probably, could you bring that way down? And so we probably want her prone, actually. Because if we did it, show you what would be bad, we could relax the second face, Alyssa. Okay, if you could face Brittany. Okay, so a bad way to do this would be to get her into the shortened position and then say, hold it strongly as you can, Alyssa. So you see, she just fell forward because of the lack of stabilization. So what we can do instead, if you want to test the infraspinatus in the shortened position, go ahead, lie prone. Doesn't matter. Okay, and maybe take your left hand and make a little pillow for your forehead. There you go, good. And so now you're holding it up like this, and you see her body is stabilizing the shoulder girdle, or gravity is stabilizing the shoulder girdle and trunk. Okay, ready, hold it up there as strong as you can. Or even this here, so you're just testing rotation, right? Hold, okay, good. Right, can you think of a way that you could test these gravity eliminated?
Have them sitting beside the table.
Okay, yeah, go ahead and show.
And then for like subscapularis, since it's internal rotation, then it'd just be rotating the arm in. And then for external rotation, just be rotating it away.
Okay, yep. Okay, good, good. All right, super job. Are you ready?
I'm ready.
All right.
Okay, so I'm doing the pec major. The action is adducting the arm and medially rotating the arm. And the origin is the clavicle, the sternum, and the costal cartilages. So, and then the insertion is the intertubercular sulcus of the humerus. So, it's a fan out like this.
Okay. Oh, Drew, actually not the sulcus. The sulcus is the opening, but
groove.
the the lateral lip. What's the official name? Do you know? Lateral lip. Okay. Yeah.
Yes.
Yeah. The sulcus would be, you know, something like in the sulcus. So the sulcus is a Latin word for valley. So sometimes like knowing what these mean will help you like describe the anatomy correctly. So continue.
And the innervation is the lateral and medial pectoral nerves, which is C5 through T1. To test this, we would do, so we'd have the patient stand with their arm at about a 45-degree angle to test at mid-range adduction. So we would stabilize on their left shoulder at a perpendicular angle and tell them not to move. And then if we were to do it with anti-gravity, I guess, we would have them lay supine on the table.
Or you can just scoot forward and ask them.
Okay.
That's a solution as well.
And then we would have them do the same thing, adduct to about 45 degrees. And then we're going to have them adduct, I guess. So, yeah.
All right. Hey, can I show something?
Yes.
Okay. So, yeah, I'll just use the skeleton. So, if I could here, so if you're had a nice description, I want you to think about it in a little bit more detail. So can you see this, for instance? It's going from that lateral lip of the groove up to the clavicle, then across, and then down. And actually, some of the fibers make it almost to the xiphoid process, or actually to the or in the direction of the xiphoid process. So like we were talking about a little bit earlier, it has this big range of fiber direction. So to really shorten them, Abby, would you be the model again?
Sure.
Okay, but go ahead, lie down supine, because your life is hard enough, and you need a break. Okay, so come on over here, so that you can see a little better. So think of shortening, bringing it, the arm, if you're taking a long moment arm, if your patient is strong, bringing the hand toward like the opposite as is. So I'm testing the left side. I bring her left hand toward her right as is. Ready, hold it. And so that's a good test for the sternal portion. And gravity is stabilizing her because she is lying down. And then for the clavicular portion, we more go up toward the opposite shoulder. Are you ready? Hold it, Abby. Hold it. Like that. Okay, good?
Yes.
All right, good. All right, great. Thank you.
She's ready.
All right.
Okay, so the latissimus dorsi attachments.
Hold on,
Is
hold
everyone
on.
listening to Allison?
So what?
Okay, everybody, let's give Allison your attention.
Okay, so latissimus dorsi attachments, spinous processes of T6 to T12, thoracolumbar fascia, iliac crest, inferior 3 to 4 ribs, and then the floor of the intertubercular sulcus of the humerus. So it's going to be kind of full span here. And then innervated by thoracodorsal nerve C6 through C8. It extends, adducts, and medially rotates the humerus. So you're going to test for length and strength. So if you'll lay down. So put your arms at your side. So to test for length, you want to have them laying with their arms at their side and making sure that their low back is flat with the mat. And then raise their arms straight over your head, keeping your back flat as far as you can. So hers would be normal because it's touching the back. And then,
Oh, hold on, I have a question.
yes.
So, why do you keep their back flat?
Do you want to prevent them from like overcompensating?
Okay, sure. Well, how is it overcompensating? So if it's tight at the shoulder, what might happen?
It's tight at the shoulders. for strength, you're gonna have them lie prone. I'm gonna bring her arm back this direction. And then I would apply force this way towards the abduction.
All right, fabulous. Okay, so can I show you guys one more thing? May I borrow your Dan, please? So if Diane is my model, so go ahead and stand on up, Diane, and maybe face Allison. Okay, well, let's see here. Actually, face the whiteboard if you would, please. All right, so lift up this arm a little bit if you would. Okay, so you actually, it is, what does it do to the humerus and the transverse plane? Say again? It internally rotates, so it's on the front of the humerus. It actually lies, its attachment is, you're doing great, but I want to tell the folks here, its attachment is right behind that of the pec major. So it's a really interesting dissection to do. You know, if you were to cut these muscles off, it would kind of be like a book with 3 pages. You have the pec major, then you have the lat, then you have the teres major. You know, that they lie right on top of each other. So again, if we could look at this one more time, if you're thinking about what it does, it goes in front of the humerus like this and then goes down, right? Okay, great. Okay, super work, Allison, thank you.
Alright, so we've got the trap, which starts from the superior nuchal line, the external occipital protuberance, and then the spinous processes of C7 to T12. And then it attaches to the chromion and the spine of the scapula, and the clavicle. And then the trap is innervated by the spinal accessory nerve, cranial nerve 11, and then it's going to elevate, retract, and depress the scapula. It's got an upper, a middle, and a lower portion, so I'm going to show you that. But I'm first going to say the rhomboid major is from spinous processes of T2 to T5 and attaches to the scapula that is innervated by the dorsal scapular nerve, C4 and C5, and it's going to retract and rotate the glenoid cavity and ear. Okay, so first we're going to test the upper trap. So I'm just going to have him sit straight, and I'm just going to apply pressure and ask him to bring up his shoulders. Okay. And then we're going to test the middle trap, so go ahead and lay prone. And then I'm going to have him AV deduct, and then I'm going to palpate the middle, and I'm going to apply pressure and have him resist me. That's testing the middle and the rhomboid major. And then for the lower trap, go ahead and put your arm in about scaption, and then I'm going to palpate the lower trap, and then I'm going to have him bring his arm to more of a flexion position, and then you can feel the lower trap activating right there. See right there. And then for the anti-gravity, what I'm going to have him do.
Okay, gravity eliminated.
Yeah, gravity eliminated, excuse me. Go ahead and lay prone again. So what I'm going to do, is I don't know if you can see this as well, but I'm going to take the weight of his arm. I'm going to apply pressure and have him push into my arm, my hand right here. And I'm going to take the weight of his arm for the upper trap. And then for the middle trap, I'm going to have him go ahead and sit on, sorry. Sit on the stool.
I really like your creativity.
So, go ahead and sit on the stool. And then we're going to just have, while the table is taking the weight of the, table's going to take the weight of his arm. Well, that's bad. No, don't do that. Come close. Well, he's just going to squeeze his arm. Okay, that's good. Okay. He's just going to squeeze his arm. And that's going to be the gravity eliminated. And that's going to do the rhomboid in the middle. And finally, for the lower trap, go ahead and lay down again.
You're getting a bit of a workout.
Again, I'm going to come underneath him and take the weight of his arm, and then I'm going to ask him to try to touch his toes. And then, if you palpate it, you can feel his lower trap working while I'm taking the weight of his arm.
Okay. That was fabulous, and I especially like your creativity for figuring out the gravity eliminated test. If I can just show one more thing. Now, Blake is young and strong, like almost everybody here, except for me. But I'm actually surprisingly strong for my age, if you were interested in that. But I'm not young. If your patient is somebody who is strong, like Blake, then you might take a longer moment arm. And let me show you something. So go ahead and lie prone, for example. And why don't we do this way? I think it'll be easier for more people to see. I'm going to scoop the table out just a tad. No, you're fine. It has, no, stay on here. Okay. The table has wheels. Your wife is hard enough. Okay. Okay. So scoot toward your right side. Okay, there we are. All right. So, for example, if we're testing the lower trap, so we get into this kind of making a V with the arm position, and since Blake is strong, and we're comparing right to left, we can take a long moment arm. Of course, this is going through the glenohumeral joint, but we're palpating the scapula. Okay, so go ahead and hold that up, Blake, as strong as you can. And then we see which moves first, the scapula, or so you do that through palpation. And is it okay if I lift your shirt up? Okay. Okay, and you can also see that. Does this show up on the video? Okay, great. Okay, so go ahead, lift on up. And well, I would palpate, but I think you can actually see which one will break first. Ready? Hold it strong as you can. So you see, actually this is interesting. In Blake's case, the scapula is breaking, go ahead, or the scapular angle is breaking before the glenohumeral joint. So Blake might actually have some work to do. Great, thank you. That was fabulous.
By any means. So we're going to look at the scapula first. I'm going to highlight it with a marker just so you all can see. But anytime that you're palpating a joint, you want to go perpendicular to the joint. So if I'm kind of here and I'm just feeling around, you're not going to get that much sense of where the joint is. It's going to be a little more foggy and gray. But if I can come and go right on top of it and feel for the angle as I palpate up, it's going to be the better way of doing it. And so with the shoulder blade, the scapula, you can see we're looking for the inferior angle, which is going to be a little bit harder to find with just a lot more muscle that goes over it. So we'll attempt to find that, and then we'll palpate up. The tricky part is distinguishing between the spine of the scapula and then the medial, the superior angle, I should say. So first, I'm going to palpate down.
Okay, and everybody do this on their partner at the time that Dr. Adler is.
We can switch back and forth as well too.
It's way easier to do it while you see it than it is to try and remember what happened and then reproduce it.
Okay, I'm mapping out really quick just so I can talk and do it at the same time. Okay, so inferior angle. So a lot of times it's easier to find the medial border, so you can just start from the inside and kind of work your way over towards the scapula until you hit your first bony ridge. From there you'll palpate down towards the inferior angle, and you'll feel where you can also have them try to tip the scapula up a little bit, kind of do a little bit of protrusion, and then of the shoulder, and then you'll feel where it comes down to a tip, and then if you come more laterally anymore, you're going to start losing it with just the muscles that are in the way, okay? So I'm going to stay on that medial border all the way up until I palpate up to the spine of the scapula, And you'll know it's the spine because if I follow that kind of ridge over, it's just going to keep on going, just like the skeleton, okay? And with this, I'm going to find the inferior portion of the spine of the scapula as it comes over, and you'll see that the inferior portion turns into, pretty much goes right into the posterior edge of the acromion. And what we're trying to find next is this posterior lateral corner, but we will come back to that in a little bit. So I want you guys to find the superior edge as well too, so you can kind of come on top, staying perpendicular and palpating over. And eventually this will run right into the clavicle. So you'll feel where it ends, and then the clavicle comes in, okay? And we'll come back to that. And then as well, if you can try, don't push too hard. The trap is going to be in the way, but try to see if you can at least make out for the superior angle of the scapula, okay? It's going to be underneath some muscle as well too, okay? Let's start on that. So finding the superior portion of the spine, of the scapula, I'm going to come forward until it runs into with the clavicle. If you're having a hard time kind of really differentiating between, okay, I can feel the spine, I kind of lose it a little bit, you can then come anteriorly onto the clavicle and get on the kind of the top superior portion of it, and you're just going to palpate back towards the shoulder as well. And so for her, I actually kind of lost it a little bit right through here. And then where the two meet, right here, is more or less the posterior portion of the AC joint. So then we'll also find the anterior portion as well too. So here's we're coming back on the posterior portion, or the inferior portion of the spine of the scapula, coming to the posterior portion of the acromion. So if I keep on coming around, if I'm not sure, am I on the humerus? Am I on the acromion? Which one am I on? Just have them just nice and easy, do a little internal, external rotation. Is it moving underneath your finger? No? Well, you're probably on the acromion. Is it moving underneath your finger? Yes? You probably have dropped down on the humerus, okay? So I'm gonna stay up there, and then you'll feel as it kind of rounds the corner, and it starts moving more anteriorly. So we have our posterior lateral corner, okay? So this is just the edges of the acromion. So go ahead and face this one now. I'll see if I won't get in the way. All right. So lateral edge now. Again, if you're not sure, because the humerus and the lateral edge are just right up against each other. They're very close. So if you're not sure, as you're putting a finger here, just easily internally, externally rotate. Is it moving a lot under my finger? No? Okay, I'm probably on the lateral edge of the acromion. And so as I come around here, I'm going to feel as it starts to kind of move around the shoulder. I'm going to find the anterior lateral corner. So we're finding the two different corners. And again, if you're like me right now, I'm not really too sure. So I'm going to have her just easily, okay, yeah, so that's it, so I'm on there. And it's just because the humerus, it's just right, it's right there. It is right in the way, and it's hard to really feel. So I'm going to mark that off, and then I'm going to keep on palpating until it feels like this is the importance of trying it out on a lot of different people. Some people you're going to find out, oh, this is really easy to feel. Some other times you do it, you're like, this is a little bit more difficult. And so I'm trying to feel where the acromion, anterior part of it, comes around and meets with the clavicle here. And so eventually you'll get in here, you'll feel a small little notch called the anterior V notch. And then if you keep on palpating, you'll end up on the clavicle, okay? It takes a lot of practice, just a lot of practice. And once you get done with your partner, try it on someone else.
And guys, like Dr. Adler was talking about with some other things, if you're not sure, then protract and retract, and you'll be able to feel the actual movement of the AC joint.
Yeah, yeah. And you'll be able to feel that clavicle especially too, if you're having a hard time really feeling for that movement.
Where the clavicle ends and the acromion starts.
Yes. All right. Let's see. Yeah, let's practice that really quick, okay? And then we'll hit groove in the lesser tubercle as well. And not only that, also the coracoid process. So for the coracoid process, a lot of times what I do is just start inferiorly to the clavicle, and I start using 2 or 3 fingers, more or less where you know that it's probably not at, and you start moving more laterally. And what you're going to feel for is really just the first joint, or the first bony prominence that you hit. Don't push too hard on it. It's going to be very tender. Yeah, go ahead.
Okay, probably everybody else is too young to remember this, but when I was a lad, of course this never happened to me because it was so good, but male 6th grade teachers, they didn't know about the coracoid. Oh, you've experienced this too. Or, you know, Dr. Adler was really good too, so he never actually experienced it, but he saw it. Anyway, so male 6th grade teachers would know that that was there, and they would pinch it to bring unruly 6th grade boys to heel. Okay, continue.
So just be careful, because it is going to be very tender. So I'm going to feel for that. If I'm unsure, if I'm like, yeah, am I on the coracoid? Or if I'm on the humeral joint, what am I going to do? Move it, yeah. So go ahead and control extra rotation. Doesn't really move underneath my finger, stays pretty still. I can feel the muscles activating, right? But that bony prominence does not move. So what I'm going to do is the quick way, the Dr. Hackney, I like this way. I did not learn this until
you were a lab assistant for this, right?
Yeah, I think I was, yeah. So it's not locked. It is kind of a quick way to distinguish between the greater bicipital groove and the lesser tubercle. So if the arm is fully internally rotated, where is the lesser tubercle? Are you going to be able to feel it or find it? No, you're not. It is
too medial.
Somewhere back in here. But what is in the front of the shoulder? The greater, right? So that is your first distinction. So if I know that if I'm in the front of the shoulder and I have my hand resting on the shoulder, kind of use my middle finger, I'm going to put pressure on the shoulder. I know that they're internally rotated fully. They're going to be on the greater tubercle. And then as I move more, kind of a neutral position, I'm going to be nearing that bicipital groove. And so again, what you can do is kind of play around with it a little bit, but you're going to be falling in between the greater and the lesser. You're going to be falling right into that bicipital groove, and with that, you might actually feel for that biceps tendon. If you're not really sure, you might be able to feel it if you activate it. So go ahead and push, and you can kind of feel that the tendon pushes up into your fingertip. Okay, and then all the way externally rotated. If I keep my finger in that same position, what's going to come into play? The lesser, yeah. And so I know that the lesser is in that general area, okay? This can come in handy if you're like